Okay.
Welcome, everybody. My name is Lukacs Lesinszki. I am originally from Hungary, and I would like to introduce you a really interesting but often difficult to diagnose, therefore often misdiagnosed disease group, the brachial plexus disorders. But before we dive into the details, I would like to introduce you the anatomy of the brachial plexus because I think this is crucial to understand the clinical symptoms. And then I will move to the classification of the brachial plexus disorder. And at the end of my presentation, I would like to show you a case report or a case I encountered during my rotation here in Virginia. So let's take a look at the anatomy of the brachial plexus. The brachial plexus arises from the cervical segment C5 to T1. And these roots will further unify to superior trunk, middle trunk, and inferior trunk. And then these trunks will give anterior and posterior divisions. Later, we have lateral, posterior, and medial cord around the axillary artery. And these cords will give the big branches of the nerves which supply the muscles in our hand and in the upper extremity. For example, the musculocutaneous nerve, the axillary nerve, the radial nerve, the median, and the ulnar nerve. These nerves are crucial for the proper functioning of our hand. That is why the injury of the brachial plexus can have a really big negative impact of the patient's life. That is why we have to take this disease really seriously. I classified these diseases in 3 groups: the compression, the trauma, and the inflammation of the brachial plexus. Let's review them one by one. I would like to start with the compression of the brachial plexus. It can be either the level of the spinal cord or in the peripheral nerves. I would like to talk about first the spinal cord compression. It's a general rule of thumb that the symptom of the spinal cord compression always have a local part, so it always cause neck pain or shoulder pain, and the pain can radiate down the upper extremity according to the dermatomes. For example, if somebody have C6 compression in the level of the C6, it can cause shoulder pain, which radiates down the thumb. We can see it quite properly in this image. And the spinal cord compression can lead to diminished reflexes as well. For example, the C5 compression leads to diminished biceps reflex. The C6 compression can lead to diminished brachioradialis reflex. There is no good bedside test for diagnosing spinal cord compression, but we can use the so-called Hoffman's test for diagnosing it. If we flick the middle fingernail of the patient, and if we can see the movement of the thumb, that is considered as a positive Hoffman sign. And we can see that the sensitivity and the specificity of this test is not that high, so the clinical value of this test is questionable, but we can still use it as a bedside test for the initial diagnosis. Let's move on to the nerve compressions. I would like to talk about one of the most frequent nerve compression, the so-called thoracic outlet syndrome, or TOS. We can classify the thoracic outlet syndrome for neurological thoracic outlet syndrome, vascular TOS, or true TOS, according to the entrapped structure. For example, in the case of neurological TOS, we can talk about the entrapment of the brachial plexus, while in vascular TOS, we see the entrapment of either the artery or the veins. Now I would like to focus on exclusively the neurological TOS because I would like to talk about only the brachial plexus disorders. So let's review the diagnostic criteria of the neurological TOS. So the brachial plexus, which is illustrated with this yellow structure in this figure, have to go through really narrow spaces, like the scalene triangle, the costoclavicular space, and the pectoralis minor space, so it can be easily compressed, easily entrapped. So that is why the compression of this nerve is quite frequent. And how can we diagnose the compression of this nerve? 3 out of the 4 following criteria should be met if we want to diagnose the neurological TOS. So I just want to highlight the main information. I know that there are a lot of text on this slide, but in the case of neurological TOS, the patients almost always have local findings, so neck pain or shoulder pain. And this TOS can lead to peripheral findings as well, so the numbness or tingling of the hand. And the absence of other reasonably likely diagnosis can be considered as a diagnostic criteria. And if we inject anesthetics to the painful site, and if it relieves the pain, it can be the sign of the nerve compression as well. Okay, let's review some useful bedside tests for diagnosing the neurological or other kind of TOS. For example, we have the so-called Roos test. In this case, we ask the patient to raise their hand and open and close their hand for 3 minutes. And if this maneuver exaggerate the symptoms, the numbness or the tingling, it is considered as a positive test. And the other test is the so-called Edson test. In this case, we ask the patient to move their hand towards the painful side and take a deep breath. And if this maneuver can exaggerate the symptoms, we consider this as a positive test, which can be the sign of the nerve compression. The sensitivity, specificity, positive and negative likelihood ratio of this test is not too high, so the clinical value is questionable, but we can use it as an initial test. Okay, so let's move on to the injury of the brachial plexus. What can cause injury? It is mainly caused during the delivery, so it is a kind of obstetrics injury. One of the most common injury of the brachial plexus is the so-called Duchenne-Erb palsy. We can further classify the brachial plexus injuries according to the Lukacs classification, and this is the less severe injury. In this case, only the C5 and C6 segment is injured. So this kind of disease group has a good prognosis, but the more segment is injured, the worse the prognosis are. So in the case of the group 4 brachial plexus injury, the prognosis is really bad and the patient often not recover. And we have the Klump's palsy as well, but it is not the part of the Lukacs classification. The injury of the C8 and T1 segments can lead to Klump's palsy. It is a quite rare condition. It can lead to claw hand, so the clawing of the hand. Okay, I just want to have you to take a quick look at this really severe group 4 brachial plexus palsy. You can see here the atrophy of the pectoral muscle and the weakness of the hand. We can see here the coracoid and the acromial process because the deltoid muscle has an atrophy as well. And we can see here the winging of the scapula. And in really severe cases, the sympathetic nerves are injured as well. So we can see the classical Horner sign as well. So the ptosis, meiosis, and ophthalmos. Okay, so we reviewed the compression and the traumatic cause of the brachial plexus injury. These can all lead to the inflammation of the brachial plexus, but if the inflammation appears alone, this is a different kind of condition. Now I would like to review this condition. This is the so-called brachial neuritis. This is a quite rare condition. It is difficult to diagnose, but according to the von Alphen criteria, we have to consider brachial neuritis if the patient presents with with acute onset of very severe shoulder or upper arm pain, and if the pain is worse at night, and if the symptoms are asymmetric. So if these criteria, if the patient met with these criteria, we have to consider brachial plexus neuritis. We don't have a good bedside test for diagnosing this condition, but the so-called scapular dyskinesis, what we can see here, or the winging of the scapula, can be the sign of the brachial plexus neuritis. Okay, so we reviewed the main causes of the brachial plexus neuritis. Now I would like to introduce you this case I encountered during my rotation here in Virginia. I met with a 39 years old right-handed patient who presented with acute onset bilateral upper extremity pain, weakness, and numbness. He was unable to extend his fingers. So it is a really devastating condition because he works as an electrician. So he has to use his hands every day. So we should take his symptoms really seriously and we should go the bottom of it. I would like to just highlight some important facts from his history. He was diagnosed with brachial plexus neuritis in 2019, but it has since completely resolved after corticosteroid therapy. So he completely regained the function of his hands. And he frequently lifts heavy objects because he's an electrician. And it is really interesting that he lost 70 pounds in this year. And there was an event when he consumed excessive vitamin B supplements and energy drinks, and he experienced arm pain, but it completely resolved. So what would you think? What are our differential diagnoses in this case, according to the cases or the causes what we reviewed before? So it can be, for example, the most obvious one, the relapse of the inflammation. Because he already had brachial plexus neuritis, maybe it is a relapse of this disease. And the other causes, it can be trauma, so the traction of the brachial plexus can lead to these symptoms as well. And he lost voluntarily 70 pounds, but we don't know whether it was completely voluntary or not. So maybe there is a tumor, a pancreas tumor, which compresses the brachial nerves. So for addressing these questions and finding the best diagnosis, I first perform physical examination. Now I would like to just highlight the most important part. So the patient was completely unable to extend his fingers. And there was a significant weakness of the right triceps, but the left triceps force was intact. So there was an asymmetry between the two upper extremities. And I could see the winging of the right scapula as well. He had decreased sensitivity in the radial nerve distribution in both of his hands. The left bicep reflex was normal, but I can't measure the right bicep reflex because of the tenderness of this area. And the Hoffman and Turner sign was negative, and other signs were negative. So based on this exam, we move forward, and yes, I take a picture of his numbness, the area of the numbness of his hands. And yes, as we can see, it's followed the radial nerve distribution. So he experienced pain in this numbness in this area. And we performed EMG and nerve conduction studies. So in the electromyography, in the C7-T1 muscle distribution, we could notice some kind of giant potentials, which can be the signal of the nerve injury. But the other kind of EMG signals were unremarkable. And the nerve conduction study was almost completely normal, but the radial nerve signal could not be obtained during this study. So, and last we performed imaging, cervical and brachial plexus MRI, and we found that the brachial plexus is completely intact. There is no compression, no tumor around the brachial plexus, and there is a mild protrusion of the disc in the C6, C7 segment, but it is clinically irrelevant in this case. So based on these symptoms and the imaging, we diagnosed him with brachial plexus neuritis, and he was commenced on corticosteroid, and he responded really well, so the pain has completely resolved. Physical therapy was scheduled, and we planned IVIG for his therapy. So based on this, it was a relapse of his previous brachial plexus neuritis. Now I would like to just quickly summarize the main information about this disease. So the brachial plexus neuritis, or also known as Personage-Turner syndrome or neurologic amyotrophy, is a quite rare disease, but new studies suggest that it is often overlooked. So maybe the prevalence is higher than we suggested before. The etiology is unknown, but autoimmunity is suggested. It typically presents in men around their 40s, and it is mainly a clinical diagnosis, so there is no specific test which can confirm this condition. And the therapy consists of glucocorticoids and physical therapy. So that was my case I encountered with in this rotation, and with that I would like to thank you, Dr. Bernard, for this great opportunity to work with him here in Virginia. I would like to thank you, the staff, for their help, and I would like to thank you for your attention.